Hello my dear friends, I'm Dr. Vaishali Bharambe. I've been teaching anatomy for more than 25 years and I love it. Today, it's about the patella or the kneecap. A request to you would be, please sit for the lecture with the patella in your hand. Okay, and a femur as well if possible. It will help you to understand the lecture faster and better. Right, so patella. So what is patella? Patella is a sesamoid bone. I'm sure you know that. It's the largest sesamoid bone of the body. Question, what are sesamoid bones? So, take a look. Sesamoid bones are bones that form in a tendon. See the red letter T to remember. They ossify late in life. They usually have or are close to some kind of articulating surface. So they themselves have an articulating surface with which they articulate with some other bone. They are devoid of periosteum and they have no haversian system. Okay, so they are bones but they have no haversian system. So how will you remember this? The owls always prefer hooting. The tendon. O, ossify late. A, articular surface. P, no periosteum. H, no haversian system. The rest is up to you how to remember this. This is how my students remember it. Okay, so we know what are sesamoid bones. Therefore, we are pre-warned that we are going to find all these features in a patella. Right. So, patella is located in front of your knee joint. This is the lower end of femur, this is the upper end of tibia, and here is your patella, articulating with the anterior articular surface of femur. Right. So, it's a somewhat triangular bone. See, take a look. See, it is a somewhat triangular bone. It has a broad upper surface, it has a narrow, pointy lower end. Okay, an anterior surface and an articular posterior surface. Okay, and then if you know the side, then it has got 1 and 2 borders. Okay, if you rest the patella on the ground with the apex pointing away from you, then the side to which the patella falls, the patella belongs to that side. I'm going to do this with you again and again. I can see this triangular bone, apex pointing downwards, right? So I'm going to just rest it on my hand. Apex is pointing distally. The bone has tilted on the left side. So it is a bone of the left side. One more try, come on. Where is the apex? Here. I'm going to just rest it on my hand. It's falling on the left side. It is patella of the left side. One more. Okay. Where is the apex? Here is the apex. Okay. So I'm going to just drop it on my hand. This time it's falling on the right side. So it has to be the right side patella. That's how easy it is to do side identification of patella. Very easy. I hope you got that. So here you are seeing the triangular patella. It has an apex and a base. That upper border that I was trying to show you here is called as the base. It has got medial and lateral borders. I know this is right side, so this has to be the medial border. This has to be the lateral border. It has got a rough anterior surface. Can you see how rough it is? Okay. And it has got a very articular posterior surface. Done. That's all there is in patella. Okay. Come, we'll discuss each of these. The apex of patella here gives attachment to your favorite ligament, ligamentum patellae, extending from the patella down to the tibial tuberosity on tibia. See here, on the tibia over here, it goes and gets attached on the tibial tuberosity. So the base now. So if you know that this is the base, this upper border is the base, and you can see that 3 layers of muscles are attached to it. Let's understand. Anteriorly, there is insertion of rectus femoris muscle. Behind that, okay, in the medial 1/3 is vastus medialis. Lateral 2/3 is vastus lateralis. You can see on both sides the muscle attachments are extending further on the lateral border and on the medial border. Okay, so upper border there is rectus femoris, Behind that middle 1/3 vastus medialis, lateral 2/3 vastus lateralis. And behind that here is the vastus intermedius. What are these four muscles? They are the quadriceps muscles. Okay, so let's take a look. What are quadriceps? Quadriceps are four muscles together. Rectus femoris here, medial to it vastus medialis, lateral to it vastus lateralis, and deep to it vastus intermedius. Four muscles together form the quadriceps. The bone formed in the tendon of quadriceps is the patella, which is why we call the patella a sesamoid bone. Through the patella, the tendon extends forwards, called the ligamentum patellae, and inserts on the tibia. Okay, so that's how your quadriceps is able to act on the tibia through the patella, okay, and help in extension of your knee joint. There. Before we discuss any further about the muscle attachments, let us finish the discussion of borders. Okay, so this is the lateral border, this is the medial border. Extending along the medial border for the upper 2/3 of medial border is vastus medialis. So quite a bit on the medial border, your vastus medialis is attached, and the lower part gives attachment to medial patellar retinaculum. Now, lateral border, the attachment is only upper 1/3. On the medial side, it's upper 2/3. On the lateral side, vastus lateralis extends only to the upper 1/3. Rest of it is lateral patellar retinaculum. Why the difference? What is going on? How does it matter? Take a look. So why this difference? Patella tends to get displaced laterally. That's a problem with patella. Whenever there is a pull by the quadriceps, patella tends to get pulled laterally. Okay, you don't want your patella to get subluxated or dislocated laterally. So what has the body done? It has reinforced the vastus medialis along the medial border. Because of that extended attachment, the patella is held on to, preventing it from getting laterally dislocated. To counter this lateral dislocation, vastus medialis gets inserted along the medial border. Vastus lateralis gets attached more superiorly. Okay? This anatomical asymmetry helps to maintain the patellar alignment at the knee joint. Now, what is patellar retinaculum? I have talked about medial patellar retinaculum, lateral patellar retinaculum. Actually, they are a part of the capsule as well as the muscles that are present here. Okay, so they will help to stabilize your patella. They're kind of fibrous bands. A lot of books have described them as thickenings of the capsule itself. Basically, they are fibrous bands that are extending from your quadriceps down to the patella to hold on to the patella. Okay, further reinforcing, of course, the knee joint. Medial patellar retinaculum formed by fibers of vastus medialis and medial joint capsule. Lateral, vastus lateralis and lateral joint capsule. Function is to help in management of the patellar alignment to the femur during knee movements. Right, let's talk about anterior surface. Can you please take a look at the anterior surface of patella you have? You can see that the anterior surface is quite rough. Why is it rough? Take a look. This is the rough anterior surface. It's covered actually by the quadriceps fibers. So the fibers are extending on the anterior surface, forming these bony ridges. And the very prominent ridges are actually the ossified quadriceps femoris fibers. Okay. So anterior surface will be rough. It will show fibers of quadriceps which might have ossified on it. Turn the bone over. We are now looking at the articular surface of patella, with which it goes and articulates with the lower end of femur. Okay, so you can see that this articular surface, at the apical region, the posterior surface of course gives attachment to ligamentum patellae. The rest of the surface is divided into larger lateral side, narrower medial side and narrowest medial most side. So if you take a look, this is the larger lateral side, This is the less large medial side than the medial most side. We'll talk about this some more. Okay. So this whole thing corresponds to the surface provided by the femur for articulation. This patella is going to articulate with the articular surface on femur. See here. So if the femur provides that kind of surface, the patella has to correspond. Okay. So here's the lateral articular surface of patella. You can see that it's quite extensive. Here's the medial articular surface, which is comparatively narrow. Right. So what is the relevance of this division? Larger lateral, narrow medial and all that. How does it matter? Come. The different parts of patella meet femur in different positions of flexion and extension. This is the medial ridge dividing the two medial and lateral surfaces. In a relaxed knee, just relax your knee, keep it on some kind of surface, keep it relaxed in full extension. You will find that you can actually play with your patella. Your patella is no longer articulating with the femur. You can move it around. Okay. But in ordinary extension, okay, the upper two articular surfaces are articulating with the femur. Much of the patella is distally free. When you semi-flex your knee, the middle facets are articulating with the femur. When you very much flex your knee, the lower facets are articulating with the femur. And if you complete your flexion, then the medial most part of it is articulating with the femur. Okay, for doing this, you must perform these actions and palpate your patella simultaneously. You will find yourself understanding this much better. So, I've already told you side determination. Just do this once for me. Apex always pointing distally. Just pick up the bone and rest it on any horizontal surface. Whichever surface the patella falls on, the patella belongs to that side. It's very easy, but to be practiced. You cannot just randomly get it right, because which is the apex becomes a little difficult to remember. Ossification, you already know it ossifies late. The ossification may begin in the 3rd to 6th year. Some say it has only one ossification center. Some say there are multiple ossification centers. Bottom line is, ossification goes on late, typically to 10 to 12 years, because it's a sesamoid bone. Delayed ossification may be also seen in some nutritional deficiency conditions and so on, but that is true for all ossifications. Let's talk about some fantastically interesting applied aspects. Okay, so we are almost home there. Just have some patience and we are done. Okay, first, patellar fractures. When will you have a patellar fracture? Maybe if you fall on the patella, you will fracture it. Maybe if you have a weak patella and your quadriceps contracts, your patella can just crack. You can see this patella is having a transverse patellar fracture. You can have various types of patellar fractures, but this one is showing you transverse patellar fracture. How will you treat it? Of course, you'll immobilize the patient, you'll try and get the patella to unite, but many a times you might have to do sutural wiring because of lack of periosteum, it's not going to heal. Remember, effect of absence of periosteum on healing of fracture of patella. Absence of periosteum compromises its ability to heal fractures, and that's why surgical fixation of patella is very often needed. Right. There is some very horrible activity happening when sometimes to torture a person, the kneecap is shot off. In such conditions, results in shattering of the kneecap, which is very difficult to treat, and it inflicts physical as well as psychological trauma. We as anatomists want to know what will happen in the absence of patella. Yes, the action of the quadriceps tendon will be compromised. Okay? Patella is central to knee extension. Blasting it can instantly disable walking by disrupting the extensor mechanism of quadriceps muscle. Right. What is bipartite patella? Sometimes patella may develop a separate ossification center, resulting in patella in two bits as shown here on the screen. It can sometimes be mistaken to be a fracture. Patellar dislocation or subluxation. Remember, this is a very important thing. We will need to discuss it. We've already touched on it earlier. We will touch on it again. So if you look carefully, patellar dislocation or subluxation occurs when patella slips out of the articular surface provided by the femur. Cause is trauma, weak quadriceps. When patella dislocates, you can see here there is a ligament, medial patellofemoral ligament. So if the patella moves laterally, this ligament gets stretched or torn. Okay, surprisingly, not much is discussed about this even when we do the knee joint, but this is a very important ligament from point of view of stability of patella. Okay, take a look. This is the anterior view on the upper side and the inferior view at the lower side. This is normal. Patella in the center, quadriceps femoris, ligamentum patellae, all is fine with the world. Patella is sitting snug in the surface provided by the femur. This is the second image where patella has been pulled laterally by maybe a strong vastus lateralis. It is subluxated. You can see how it has left the surface provided by the femur for articulation. It is subluxated. In the third case, you can see that it's just jumped the area provided by the femur. It is dislocated. This inferior view gives you how it is completely overriding the surface provided by femur, coming to lie lateral to it. This is a dislocated patella. How is the anatomy aligned to prevent a subluxation or dislocation? We've done this today. We're just going to run through the points once more. Vastus medialis has a longer attachment of patella compared to lateralis. So it will hold on to the patella, preventing lateral subluxation. Second, medial patellofemoral ligament. It's a ligament that extends from the superomedial angle of patella to the femur, just holding on to the patella, preventing it from getting laterally subluxated. Finally, the lateral femoral condyle itself rises up as shown here, preventing any easy subluxation. So the whole body has aligned itself to prevent lateral subluxation of the patella, which however does happen pretty often in some patients. If you have one subluxation, you're likely to have it as a repeat injury. Patellectomy. Would you do a patellectomy? Why would you do a patellectomy? It's considered only when all other treatments fail. Severe patellar fractures that cannot be reconstructed will go in for patellectomy. Okay? Sometimes infected non-healing fractures of patella can also go that way. So what are the consequences? Obviously, knee extension is reduced. If you passively extend the knee, yes, you can. But remember, patella is acting as a fulcrum for action of quadriceps. So when the fulcrum is gone, the action of quadriceps is definitely compromised. And that's why you will not have a fully extended knee. Passive extension, yes, but active, no. Difficulty in climbing stairs, there is an altered patellofemoral mechanics basically. So, surgical modifications, how would you modify? Once you've removed the patella, what modifications are needed? Quadriceps has to be attached directly to the ligamentum patellae tendon, obviously. Otherwise, how will it act? So, this much of surgical modification is definitely needed in case of patellectomy. Finally, let's talk about reflexes. Now, this is something important. I can't stress enough on it. Why has it come at the end of the discussion? Because that's the place for this discussion. So we know that human body is taken through two types of reflexes. We have superficial reflexes, we have deep reflexes. In superficial reflexes, you use the skin and mucosa strokes to study the body. These are polysynaptic involving skin and multiple interneurons at the level of spinal cord. Examples are superficial reflexes, plantar, abdominal, cremasteric, corneal. They're all superficial reflexes. But let's come to deep reflexes. In deep, there is a monosynaptic reflex, direct communication between sensory and motor neuron. You can tap a tendon. The afferent limb will carry it, the efferent limb will cause contraction of the muscle, and you will see action. Examples of deep reflexes: patellar reflex, Achilles reflex, biceps reflex, triceps reflex, jaw jerk. Okay, today we're talking about patellar reflex. Also called patellar tendon reflex, it's an example of deep reflex. It is used to assess the stretch reflex arc at the level of L4 spinal cord. Muscle spindle fibers in quadriceps, femoral nerve follow the trajectory. Spindle fibers in the quadriceps, femoral nerve, spinal cord L4 level, efferent motor fibers coming back to the quadriceps. All these are tested. What is the procedure? You're going to tap the patellar tendon. Let's take a look. So that's the person's quadriceps, that's the patella. Okay, that's the spinal cord at the level of L4. When you tap the tendon or ligamentum patellae, what happens? What happens is stimulus is picked up by the afferent fibers in this muscle spindle of quadriceps, carried back through the femoral nerve to the spinal cord, where it synapses with the efferent neuron in the anterior gray horn, which then carries this information back to the quadriceps, and the quadriceps contracts. What will happen if the quadriceps contracts? Your leg will move forward. Your leg will move forward. What is that called? Okay. It is extension at the level of knee joint, which is the effect of your test. Okay. So when is the jerk exaggerated? When will you have an exaggerated knee jerk? Okay, when you have a motor neuron lesion, when you have anxiety, when you have electrolyte imbalance, you will have a very severe reaction to this test. When do you have it diminished or absent? You're stroking the ligament, but you're not seeing enough response. Loss or element, low motor neuron lesion, or you have poliomyelitis, you have muscle disease. In that case, you will not see an adequate knee jerk to your test. Okay, so a positive patellar tendon reflex confirms functional integrity of L4 spinal segment and femoral nerve, and any deviation can help you to localize neurological symptoms. Please do study this to understand the knee jerk or the patellar tendon jerk. So I've taught you quite a bit today under the auspices of this tiny little bone, the patella. Okay, I hope you enjoyed this lecture. I've asked you a few questions. You will find the answers. You will find some more additional information in the notes section. Do study it. Do carry out your own personal exploration of this very different bone called the patella. Thank you, and I'll see you in my next lecture.